Good morning. That worked well, did it, Steve? Welcome to today. I was just reflecting on what the title for today, Something Old, Something New, and I've just said to Steve it could be a little bit prophetic this weekend, because who knows, we might end up with something old, we might end up with something new politically. But today we are going to have 5 excellent speakers, I think, and we will be discussing something old, some old diseases that are actually starting to re-emerge, and some newly emerging diseases, plus a fair bit of other information which I think you'll all find quite interesting. So Steve Carmody, who's Chief Operations Officer, will give us a brief half-hour welcome, and then Madeleine McPherson should be here for about 9:30. Thanks very much.
Thanks very much, Norman. Look, I'm delighted to be here this morning for this infection prevention and control seminar, and it might be something old. I think most of us are reaching an age in our healthcare lives that are probably more leaning on the old, but that's the way the world is at the moment. I think they say the new workforce in the future will be women with older children, so that's where we'll find new workforce, and it's an interesting study into what their expectations and needs will be. So we're part of that cohort, at least in the older people with children bit. But look, I just wanted to make an acknowledgement and welcome you all here, but I want to acknowledge, I'll acknowledge Madeleine McPherson when she comes here, who's chair of our National Infection Prevention and Control Committee. She's, I was going to say to her if she was here that the word iconic is a very bad word, because it's overused, but she has been a highly reputable infection person in Western Australia for many, many years, and we're just delighted to have her with all her wisdom taking the lead at a national level. I also want to welcome those of you who are link nurses within our organisation. This strategy, I think, has worked really, really well in a very diverse type of work where we're in many people's homes, and it's very difficult to have a sensible and coordinated system, and link nurses seems to be a model that where we are today is really, really critical. So for those that have put their hands up and committed to it, and I know you have been absolutely committed to the role, welcome and congratulations for taking that role, and you have our gratitude as an organisation. But I'll talk a little bit more about that in a while. And finally, I just want to acknowledge Kate and Norm for their work that they've put into having what I believe is a really professional day, that if you had advertised it externally to the organisation, I'm sure it would have attracted a number of people. Not only do we have Madeleine speaking, who, as I said, is well known in the space. Those of you about my ilk would remember Professor Charles Watson as the Principal Medical Officer in the Health Department, and also a major public health leader in Western Australia. He also went to New South Wales, I think, in the past. So a very eminent speaker from that point of view. Dr. Madeleine Hassel, who has just joined our organisation as our infectious disease physician, or one of our infectious disease physicians on a sessional basis, and she is sort of the new world of infectious disease generational doctors who are going to bring a lot of knowledge into the space that we're in. Dr. Justin Waring, I think, as Norm was saying, some diseases, something old, something new. I trained at Sir Charles Gardner Hospital, which about 20 years before I started training was the chest hospital in Western Australia, and they used to put the mattresses up on the roof to give them sunshine, and everyone thought TB was really over. And so they converted it into a tertiary hospital, and now we find that TB is starting to ravage the world again, particularly even in the Western world. And finally, Professor Tom Riley, who is a medical scientist and again a professor. So he's going to talk about Clostridium difficile, again another disease that's been around since Methuselah, but seems to be causing problems in the health system again. So a really very professional program today, and I hope that you'll thoroughly enjoy it. And I'm going to try and make myself get back here. I've got a couple of appointments, but I want to make sure that I pick up some of this clinical and informational inputs from that point of view. Yeah, I just wanted to say a little bit about infections and diseases in a sense from my point of view. I came to nursing very late at the age of 23. Everyone else that was in my PTS group, which was called the Preliminary Training School, was just had left school in a sense. And I'd worked for a number of years. It's hardly work, it was just trying to find something to do in the social services sector. I'd been on Aboriginal missions in the north, and I'd run with my wife a women's refuge in the middle of Perth, and I'd been in the Housing Commission's Homes West, as it was called. State Housing Commission was called then, now Homes West. So when I went to nursing, you know, I wasn't in that space. I'd heard my wife, who was a nurse, talk in languages that I couldn't understand, a lot of Latin and the like. But three things struck me when I went into that PTS, which is, for those that are not nurses, is a sort of 9-week, I think it was, 9-week preliminary school. And by the end of that, you knew whether you're going to nurse or not. So you either stayed or you left, and a few people left at that point. But there were three things. One, I'd never done anatomy and physiology. Quite extraordinary when you first get confronted with that at a later age, just how amazing the body is and how it interfaces with each other. Madeleine, how are you? Welcome. Trying to sneak in. No, I've said my compliments about you, Madeleine, but you're most welcome. So at that age, just the way the human body functioned was really quite extraordinary in my mind. You know, just how it linked together and all the chemistry and all the functional changes and all the physics that went along with it. Just quite extraordinary. But two other things stood out for me. One was a lesson in microbiology, where I think the first thing that was said was a rule that I've kept in my mind since then. It was about organisms, but it was also about the human person, and it was also about societies. Only those that adapt will survive, the others die. And we're seeing in this infection control day today a lot about adaptation of things we perhaps had hoped wouldn't adapt. But you know, some of those diseases are true, but it is true of human beings, and it's very true of our organisation that if you don't adapt, you will die. And our organisation is going through enormous change, and we'll talk a little bit about that in some time too. But you people are part of that. The model that we're using as a national model for infection prevention and control across the community sector is a really new sort of space. And again, with Madeleine as our chair, we're thinking about the best way to make sure that a society like ours can manage that. And I said there were two or three things I learned in that PTS school. The other one was just some of the history of infection control and infection prevention. And that was, they were quite amazing, because it wasn't that long ago. It was 173 years ago, so it was about 150 years or 140 years from when I started, that, you know, people like Semmelweis would recognise that there was a problem between the way the midwives delivered babies and the way that doctors delivered babies. The ones that doctors delivered, the mothers died at quite a high rate. And that was really because midwives didn't do autopsies, and doctors and student doctors did autopsies before delivering babies without washing their hands. And he understood that very early idea that if you've got to separate patient from patient, you've got to wash your hands, you've got to make sure you're gowned up and you don't mix patients and touch patients without some sort of intervention between. So separation was really critical. And then there were other people, you know, like the Listers of this world, and Jenner. And I always thought about Jenner, who apparently inoculated a 6-year-old child with cowpox, and then took a live smallpox bug and injected the child with that after he developed some immunity. And I always think, you know, I'm not sure it would have ever passed an ethics committee, but it probably didn't matter because the child was probably from a workhouse. I don't know. I'm reading that into myself, but it sort of says something about our society and how it might have changed. But I'm not sure you could inject the live smallpox vaccine to a 6-year-old child to test whether his immunity was working or not these days. So it's just interesting that it's a very short time since the actual prevention of infection has taken place, and so much has happened. And I think at the end of my training in 1982, I think we thought we had infections covered, you know, and quite clearly we've misused the way that we've managed those, and now they're coming back as a major disease process. So I just want to talk a little bit about this idea of infection prevention and control in the community. And I think it is a real challenge, and it's been a very interesting challenge for us as an organisation and through our national committee. But when you think about it, managing infections in a community setting is a fairly uncontrolled environment. Now, how do you assess risk? You know, how do you think about prevention? How do you put in controls that you know will work? What are the action plans you do? And how do you know you've been successful? What are your measures? And I know that Norman and all of us on that committee in the past and even now worry about surveillance. How do you measure our surveillance for where we cause infections or not? And that's a major problem for us to prove that we are using systems that actually work. And why is it such a challenge? Because in the Silver Chain group, RDNS and ourselves here, and we're in Queensland, and next week there'll be an announcement about New South Wales. And we've got no one from South Australia, none of our colleagues from South Australia, unfortunately, but Wendy is as close as we come. She's about 3 kilometres away from the South Australian border, is that right? So welcome from Euclid. 15, oh, well, you're hardly South Australian. But often we know that it's easier for South Australia to go and collect some of the patients that have road accidents than for us to do it in Western Australia, even if they're on our borders. But across Australia, we have 60 households that we attend every year, and they're uncontrolled environments. So every day there are 16 to 20 live patients in all of our services across the country, all in uncontrolled environments. And when I say uncontrolled environments, South Australia's got something to teach us in a sense. But I have not heard the word squalor used as a healthcare term, but they talk about squalor, and there's a lot of literature around squalor and people living in squalor. And they actually have a package that the government asks them to deliver, which is called industrial cleans. So they go to houses, and I'm sure we've got houses like that here in Western Australia, where you can actually prescribe an industrial clean, which means getting someone not a poor old home help, but someone from an industry company to go in and absolutely industrially clean a house that's unfit for habitation or for delivering healthcare in. But these are sort of the environments that we find ourselves in. And in those clients that we look after, whether it is in home help or in any other of our clinical services, we have people with polypharmacy, we have people who are frail generally, who may have very difficult social circumstances, who have many or multiple chronic diseases. And they're always going to be people are prone to infections. And again, we have every day over 3,500 people with interruptions to the integument, to their skin. They've got broken skin either from wounds, there's over 3,000 of those, or they have PICC lines and the like into their veins, which take away the skin's protection oftentimes for the whole circulatory system and the like. So how do you control infectious diseases in that space? We also have lots of people who are post-hospital, so we're getting all those risks that come out of a hospital into the community. And again, people that go from carer to carer or from client to client needs to be very confident that you're not transferring a hospital-based infection across there. We have community-acquired pneumonias. We have lots of people receiving antibiotics, so we have to be really conscious of that. And we've got lots of immunosuppressed clients, so that's really a risk of us transferring diseases to them. So it is a very complex environment, and we, through the model that we currently have now, which is maturing over time, are really trying to work out how we make sure that we have a very solid and safe infectious control and prevention of infectious diseases. As I said, we're now in 4 states in a small way, but next week the New South Wales government will be telling the public about the fact that we will be providing palliative care into 7 of the 17 regions in New South Wales. Now, New South Wales is 1/3 the population of Australia, so that's a population of about 4 million now. We may or may not be happy with the model we've got there. They've given us a very small amount of cash to do that, but we're playing a role in New South Wales. So we're starting to get what we said on our strategic plan as an organisation to the only way that we can have a huge impact on the health and wellbeing of Australians is to have a pretty decent sized footprint. And we said, as the board has said, that we will have that decent sized footprint in at least 4 states within the next 4 years. So I think we're well and truly on our way in that sense. But I don't want that to make people who have been working so hard in RDNS in South Australia or in Silver Chain in Western Australia feel like our eye is elsewhere. You might have seen our strategies, which one is about influencing healthcare service delivery in Australia. The second one's about reach, that's the 4 states. The third one is about being a scalable, efficient model of care so that you guys who are delivering care on the front line have all the benefits of an organisation that's pointed towards you, and it may not have felt like that over the last number of years, but it's about making your work easier so that we can deliver good care. And the last one is about being a top-tier employer. But amongst those strategies, two things we're doing. The first and most important is to protect and grow our core, which is the work that you guys do in home support service, in hospice, in health, in country, in remote services. That's the first and foremost. So we're looking and always at pushing the right amount of resource in the organisation to make sure that that part of the system's well. And I think today is an example of saying, let's really make sure that the link people in our organisation are well educated, have properly been supported, and have access to knowledge that's current and evidence-based. And the other thing we're doing is growing, and we're applying part of our resources into really creating opportunities to grow in the Eastern Seaboard to meet our strategic plan. And when you ask what our real purpose is, in some ways it's been distilled down into these words, which we'll start to see more and more of. It's about providing high value care so people can stay at home. Very simple. I think we've understood that in palliative care for many, many years. What is our purpose? It's about people meeting their wishes and desires, and oftentimes that's to stay at home. So we will put every bit of our resources into attempting that to happen. But that's exactly what happens in home health. That's exactly what happens with hospital at home. It's exactly what happens when people have wound care that really has an impact on their quality of life. It's about delivering care that allows them to stay independent. So I just want to commend you to a very good day. I think it's going to be terrific. I'm more than happy to answer any questions if I can, but I just wanted to say thank you very much for making the time to be today, to actually want to improve your knowledge in the area of infection and the way you prevent infection and the way you control it and the systems that we might need to do that. But I wish you the very best, and I hope to see you a little bit later during the day. Thank you.
Thanks very much, Steve. We'll be asking some questions of you later, I'm sure. Just a point for those people who are not in this room, we actually are webcasting this whole day. We will actually stop the webcast between talks, and this will allow us to actually have 5 separate talks to upload onto our intranet at a later stage. So if you're out there watching the webcast, don't be alarmed when it stops after a talk. Our first speaker today is Mrs. Madeleine McPherson, and I don't think she is a stranger to anyone now. Madeleine is becoming very well known within the organisation. I actually used an older biography that we had from you a couple of years ago, which I'm sure hasn't changed much, except you're now working with us in a really active way. Madeleine has been working in infection control for over 30 years. Spent 18 years as infection control consultant at Fremantle Hospital. In fact, set the program up there, and now works as an independent consultant, especially in the aged care sector. And as Steve said, chairs our Infection Prevention and Control Committee nationally. Quite some time ago, about 12 months ago, Steve walked past his office and he handed me a book. He said, "Oh, this is probably more appropriate to you." It was a book he had on infection control that he'd had in his office and hadn't looked at for a long time, probably. But when I looked at it, it was written by none other than Madeleine McPherson and P.D. Mears and Jay Sedgwick. So I then proceeded to show that to Steve, and I think his eyes opened a little bit more. But Madeleine is going to give us a talk now on infection control in the community. If we can welcome Madeleine to the stage.
Thank you.
Thanks.
2 things. One, Steve, there was another experiment with vaccines, and I've forgotten which country it was in. But if you were a murderer, you had a choice of being hung or being given the vaccine, and it was the jail person's wife who was the one that was interested in vaccines. So I'll look that up again because I remember that. And the other is, what do you have to do to qualify to have your house cleaned like that? Because I put my hand up. It's one of the advantages of having poor eyesight, isn't it? It's only when your family comes around and says, "Mother, I just got a cobweb round there." And I've recently had my family around a lot because we've just celebrated our 50th wedding anniversary. And I got an email from my grandson in England who congratulated us on our maiden half century. And so I emailed him back to say that yes, it was 50 years ago since his grandfather bowled the maiden over. But the next innings looks as if it's being played on a very crumbly wicket. So we've been busy. Right, now I can't see what's up here. So, as Steve said, they've been playing around with infection control for a long time. And I think that we should be learning from their mistakes because we continue to make mistakes. And I think that's the thing that I find interesting about infection control. You see someone come up with a brilliant idea and you think, oh God, we tried that years ago and it didn't work, you know. And so we haven't got time to be mucking around with old things. So it's been around for ages, and it's not because it failed, it's because it succeeded. But infection control is changing, and one of the biggest changes, of course, is that it is coming into the home. And having spent most of my adult life in the acute care, I'm so glad it's coming into the home because I don't like what I see in the acute care these days. So it started off, I guess, once they built a hospital, you start to have trouble. Hospitals were originally built for soldiers, slaves, the poor and homeless, and if you had enough money, you stayed home. And so the worm has turned, and so they started to see outbreaks in hospital, typhus and then sepsis, and they did a study. There was a surgeon called Simpson who did the first surveillance back in those days, and he showed that you had a much less rate of infection if you had your leg amputated on the kitchen table than you did in a hospital. And that's interesting, I think, because our hospitals are so sophisticated these days. And I was speaking to a young nurse, male nurse, who'd worked in Bosnia during the war, and they were doing extensive surgery in bombed out garages, and the infection rates were the same as those that were doing it under laminar flow sterile conditions. And so that we haven't learned anything from these days. So infection was all about fear, isn't it? And you see fear today. You know, when I'm doing orientation sessions at some of the aged care facilities, I wonder why on earth they're going into looking after people, because they don't want to touch them. They're afraid of catching something from them. And I don't know about you, but I've never caught anything from anyone except my husband. You know, when he gets a cold, kissing gets cancelled, and so there were two thoughts of how infection spread. One thought it was a contagion thing, and the other thought it was bad smells. And so there were these contagious groups and the miasmas, and they still exist today. So out of that came with those with contagions, you lock them away, and we still do that, don't we? You know, blow your human rights. And so so the hospitals. So isolation was for those who had what they thought was contagious diseases. And in the case of leprosy, it was for 40 years, hence that quarantine, the word quarantine. There was no science in it. It just sounded like a nice rounded figure, didn't it? And so isolation is a bit like that. Whereas people who believed that it was caused by bad smells just ran away. Now, if you think, I believe the Greek Empire was brought down by bad smells because they used to lie around these pools having drunken orgies, and of course these stagnant pools were full of mosquitoes that bit them, and they all got malaria. So probably fleeing from a stagnant pool isn't a bad idea these days with things like dengue fever, etc. So all these illogical arguments are still going on out there. And then, of course, along came Florence. And as we heard the other day on QI, Florence did her best work when she was in bed, didn't she? She spent how many? About 20 years in bed. She was the original case of a bedridden lady. So she arrived on the scene, and she started to introduce nursing. Now her original nurses were nuns, alcoholics, and prostitutes, and I sometimes wonder how things might have changed. So I used to often think this when you'd have nurses' strikes and the nurses would come to work in their civvies, you'd think, well, you know, she had the right idea, getting them out of those clothes and into something that looked a bit decent. So Chloe believed that cleanliness was next to godliness. And of course, we certainly know that when things are clean, you feel it a lot better. But when the microbiologists came along and proved that they were actually caused by microbes, it totally destroyed her, and she never ever believed that microbes were the cause of infection. So she showed that large municipal hospitals were more dangerous than small hospitals, but she still didn't accept that it was microbes. So, but she was very clever, and I think we know today if you can con people in high places to be on your side, you've made it, haven't you? And that's exactly what she did. She was a great con artist. But apparently during the army, during the war, when she was on, I've forgotten what island she was on, she became very ill. And the first thing the authorities did was to get rid of her, because they couldn't wait to find an excuse to get her off the island. But she recovered and came back. So she didn't believe in the germ theory. When the streptococcal infection spread from one floor to another in her new training school, she just closed the school down, saying that the bug was travelling through the ventilation system. And I think we still have this sort of thinking goes on. But what she didn't know, of course, that students were running up and down the back stairs mixing with each other without washing their hands. And so both Nightingale's and Sir James Simpson, who was the man that used to do all the audits, denied that such infections were caused by microbes spread on the hands of the medical personnel that were going up and down the back stairs. So, you know, who was right then? And then, of course, as mentioned, Semmelweis came along, and you can see the interesting thing about Semmelweis, because this is in the days of streptococcal infections, you know, the puerperal sepsis. And interestingly enough, I believe scarlet fever is now going through our state schools. So streptococci, I heard once described as being fickle, fashionable, and media hungry, because it sort of comes around every now and again and causes chaos. So you can see the interesting thing about how he stopped streptococcal infections just by hand washing, because God knows when those students changed their coats last, you know, they probably slept in them, went to the pub in them, might have even done postmortems in them. And they're all sharing the same towel. And we have a generation that says, oh, yuck, I couldn't touch that towel. I wonder where it's been. And yet under these conditions, he stopped the most virulent streptococcal infections. And everything would have been contaminated because it's a pus-forming organism. So the bedding, the clothing, the floor, everything would have been contaminated. So he didn't say, oh, we've got to rush in there, we've all got to put gowns on, gloves on, and where's the disinfectant? He just made them wash their hands, and he stopped that spread of infection. And we haven't learned from that, because it's too simple, isn't it? How can it be that easy when we've got all these other scientific things around? So if you didn't wash your hands, he didn't do an audit, he didn't do a hand hygiene awareness audit, he just said that you were a murderer. And so cringed away. But the whole problem, he went wrong because he was rude, and you can't be rude to people. If you want people to do what you want them to do, you've got to suck up to them a little bit, haven't you? Be nice to them and sort of win them over. And he couldn't do that. He didn't like people. And so he had this lack of social and personal influence. But this is the best study that's ever been done, because you went from no hand washing to hand washing. We might go from one hand washing product to another product, but not from none to that. And yet we have these situations that I might have told you before. There's one particular consultant around Perth who says that hand washing is dangerous because there's all those bugs down the sink that are going to splash on his clothing. And therefore, when I ask people why I should wash my hands, all they can do is quote Semmelweis at me. Well, you know, as I've said, if you ever have to have any sort of cardiac procedure, just ring me and I'll tell you who he is. So then moving forward, which is a word that hopefully we will never hear again, we moved on to when we had antiseptic surgery, when they sprayed carbolic all over the theatres. We moved on to antiseptic surgery when they showed that microbes could be destroyed by heat. And of course, we almost got back to that because we still know that pasteurisation is adequate for most of our equipment. But of course, they moved into gowns, surgical procedures. You could choose to do them. Up to then, it was only emergency. That's why they were mostly amputations where they chopped it off. I saw a metal disc once, which I would really have liked to have as a souvenir. And it was what they used when they did amputations, because an amputation was just that. And if the assistant's hands were in the way, he might lose a finger because it was so quick. Or the man might lose his testicles or something. So they had this metal thing that went around the leg so that it protected everything, and they just chopped through it. And I saw one once, and this doctor who was clearing out his office prior to leaving, and I would have loved that. What a great talking point, wouldn't it? Have it on the dining room table. I would say, what's that all about? So then they had antibiotics, and we could start to do wonderful things. And of course, the point here is, of course, we're getting to an era where we're not going to have any antibiotics, and then will we still be able to do wonderful things like, you know, organ transplants, etc. So then along came gloves. Because they were spraying carbolic all over the operating theatre, which worked to a point mainly because it landed on the unsterile instruments and the unsterile hands of the staff. It had a devastating effect on the skin. And this particular surgeon, Dr. Holstead from the Johns Hopkins Hospital, he noticed that his scrub nurse's hands were becoming all red, raw and horrible, and he happened to love her, and he wanted to marry her, and he obviously didn't want to put a wedding ring on that hideous red hand, so he commissioned the Goodyear rubber tire company to make her some rubber gloves to protect her hands from the carbolic, and that's when the rot started, didn't it? Because that's when gloves came in. And now, of course, they were introduced originally to protect the patients from us in surgery, and then along came HIV and the worm turned, didn't it? We see gloves as something to protect us and blow everybody else. And so asepsis became very poorly understood. So then they started looking at the environment. And this was terrible. But in 1930s, bacteriologists found that they could recover bacteria from the environment. And so this led to the conclusion that the environment was the cause of infection, not the person, not the staff, the environment. And so what followed was this unproven blunderbuss approach which couldn't be measured. So they did everything at once. So suddenly you saw isolation and infection of carrier patients. This is the 30s. You saw regular swabbing of staff. And I remember even in my early operating theatre days, we used to have our noses swabbed. And if you grew anything, you were banished to the back room to make cotton balls. Do you remember? I was a very clever cotton ball maker. so it goes on, doesn't it? Damp dusting is still a ritual, and filtered air in special environments. And they did it all at once. So it was very unscientific. Something worked, but they couldn't prove what worked because they hadn't done it properly. So then came infection control. In 1950s, the first infection control nurse, Betty something or other, I've forgotten her other name, somewhere in England, was the original infection control nurse. Why did they employ them? Because of MRSA. And what did they do? Environmental swabbing. I've never been into environmental swabbing. I don't like anything that makes you look ridiculous, and I do think going around swabbing the environment makes you look ridiculous, and I'm too proud to do that. So what did they do? This time-wasting, unscientific pursuit of the environment, and they're still doing it. When all else fails, take a swab. Now, recently we've seen this document in the Australian Medical Journal of a nurse who wanted to find out why there were infections hanging around. So she went around swabbing people's lanyards. And I don't know whether any of you have read this, but surprise, surprise, she found that 71 lanyards, she actually grew something on 27 of them. So suddenly everyone had to get rid of their lanyards. And so she concluded that that infections were not caused by anything else. They were caused by badges, lanyards that may be contaminated. And I'm not sure where you put your lanyard, but she decided that they were the cause of infection. Now, we've done it before, haven't we? Neckties, stethoscopes have all been swabbed in the past. Pens, computer keyboards, white coats. And I remember at Fremantle Hospital, the director of nursing asked me to swab veils and capes so that she could get rid of them. And I said, no, you get rid of them. If you want to get rid of them, get rid of them. I'm not going to take a swab to tell you that you have to get rid of them. Get a phone call from the kitchen. We've got a dirty saucepan here. Would you come and swab it? No, you clean it. So people still think in that kind of way. So, you know, what next? Are we going to have to get rid of all our clothes and work naked with our hair covered? Because, of course, we have staph in our hair. How crazy? How much further can it go? So I have yet to have anyone explain to me how a microbe on a wall gets into a wound. How do you, unless you have someone go and lean on the wall and then bring their hand over, put it in the wound. How does it? They haven't got legs, have they? And they haven't got wings. It's all very silly and very unscientific. So, you know, the last saying that we had was bare below the elbows. So they're doing the right thing. They said, I think something has gone too far. So what was the answer? Peter Collignon is a senior microbiology lecturer at Canterbury University, and an amazing man. And his response to this lanyard business was, thus it should be blindingly obvious that MRSA readily disseminates in the environment. Thus the hands of healthcare workers will be frequently contaminated. We know what the problem is. what appears to lack is an understanding of human behaviour and the political and medical will to really do something about it. It's about hand hygiene. You touch a lanyard and then you touch the wound. Do we do that? I mean, what do they think we are? So I'm not going to get rid of anything. So as far as the environment has been shown, we know that we shed 2 million skin scales a day, and we know that 10% of them are like little magic carpets with microbes on them. But can they live outside us? Death of a microbe depends on the temperature, the humidity, the presence of absent sources of sunlight, or a protective coat. But they will eventually die because microbes need a 5-star host to survive. So when we shed them, you can still grow them in a laboratory, but they're no longer viable. They're only viable if they immediately reach another host, 5-star host, where they get the right temperature, the right food. They're living organisms. They can't survive outside a human host. So hospitals do create that sort of unhealthy environment where you have sick people with tubes, wounds, and one staff member going from one person to another person. And I think one of the biggest risk factors is, of course, the use of gloves, where they're seen as a sort of an I'm all right, Jack thing. I can go from one person to another person. So it's another good reason to be staying at home, where that doesn't happen. So isolation is another history lesson, really, with gone wrong. So in the 18th century, they had fever hospitals where for mainly smallpox and yellow fever. And if you went in with one, I think you came out with the other. And then they had locks for people with sexually transmitted diseases. I remember my father was chaplain of prenatal hospital at one stage, when the prostitutes from Rose Street, when they got a sexually transmitted disease, they were put in jail until they were clear. So he got to know a few prostitutes, I think, but in a safe environment. And then they developed the first handbook in 1977 for isolation. But then 1910 introduced barrier nursing. It's a lovely word, isn't it? People still like to talk about barrier nursing. I remember years ago at Royal Perth, when I've never worked at Royal Perth, but we can always use it as an example. When someone went into emergency department with MRSA, they used to take down the curtain screens and replace them with plastic ones so they could wipe over them. Very time consuming, isn't it? And outside you'd have a bowl with Medol in it. Anyone remember Medol? It was pink stuff, and you just dipped your hands in Medol when you left the room. Well, that was barrier nursing. But then from 1977 to 1975, they introduced category-specific isolation. Now, see if this rings a bell. This eliminated the need to think, so that when you had a patient with an infection, you didn't have to think because it was all written up on the door. So you had these 6 categories. You had strict, contact, respiratory, tuberculosis, enteric drainage, and secretions. And the cards appeared, and they're still there in some hospitals. I've never used cards. If people said to me that they wanted cards, which they frequently did at prenatal hospital, I said, fine, but there's going to be a card on everybody's door. I'm not just going to have it on these people's doors. So that started to change in 1983 when the Centre for Disease Control in America produced precautions which increase the emphasis on decision making. They at last agree that we actually are intelligent and we can think for ourselves. And it removed the need for cards. Funny about that, isn't it? People seem to be very comfortable with cards. I've often wondered what happens in a little country hospital when someone has a card on the door and everyone can peek in and see, oh, Mr. So-and-so, she's got something terrible. So this was universal precautions which came about, but it failed because it was just talking about diseases for the healthcare worker. So it disregarded infections that were spread to the patient. And it eliminated blood and body fluid precautions. I remember you used to, if you had an exposure to a body fluid, there was a chart and you could look up the chart to see whether or not that was a risk. Does anyone remember those? And so universal precautions, of course, came about as a response to HIV, and you got this sort of plague-like behaviour. This is the outfit that the plague doctor wore in the 16th century in London, and it was rather a kinky outfit because it was red leather, and you can see that he's also got a stick that he can poke his patients with, so he doesn't actually have to touch them. And the lovely beak that he's wearing is filled with herbs, so that the air he breathes in passes over a bed of herbs before it breathes into his lungs. So he probably died of lung cancer. But I think the thing that I think is fascinating with this, of course, is that the plague was caused by a bite from a tick from a rat, which could quite happily crawl up underneath that red leather gown, couldn't it? So it just shows that all this rubbish doesn't work. And so it was the result of multi-resistant organisms plus tuberculosis got rid of universal precautions. Because you'd say to someone, this patient's got TB, and they'd say, oh yeah, that's right, universal precautions, and you'd feel like slapping them because it didn't work. So body substance isolation referred to all body fluids, but it failed because it resulted in heavy use of gloves and poor hand washing, which resulted in many outbreaks. So in 1994, I was actually at a conference when a fellow called Haley from the Center for Disease Control in Atlanta, who came from Dallas, Texas, and got up at the podium and said, JR said to say hello. So I presume that was from Dallas, the TV series, which I didn't watch. He actually launched standard precautions. And standard precautions was because everything else had failed. It was a new system because America was already beginning to see multi-drug resistant tuberculosis and also multi-drug resistant microbes, and none of the other previous precautions worked. So interest in communicable diseases, and hospitals were experiencing endemic and epidemic outbreaks of antibiotic resistance, and so that's when standard precautions came in. And I'm a great believer in standard precautions. So standard precautions simply is what we've always done before the Americans started interfering with all their stupid isolation handbooks and things. It's what we were always taught: good hygiene, good hand washing, protective barriers when you need them, and good management of sharps. And that makes sense to me. And the only time when you really need to do anything differently, of course, is for these infections spread by the airborne route, things like measles and chickenpox, or by the droplet route, things like influenza and whooping cough, etc., which is when you maybe need to do a little more. So standard precautions has also been blown out of all proportions because people don't see what it originally was. And it originally was just good hand hygiene, looking after your skin, because remember the good Lord gave you 3 layers of skin to protect you. I don't know about you, but I've been accused of having more. But they are there as your natural protection, so you've got to look after them. And as far as PPE is concerned, they were designed purely for handling blood and blood-stained body fluids. Someone asked me the other day, what would happen if you got feces or blood on your hands? And what would happen? Nothing, would it? Nothing. Only if you then put your fingers in your mouth or something. I mean, it's just people have got this awful fear. And someone said to me, what if you've got nicks in your hand? And I remember when AIDS first came along, we still weren't wearing good gloves in those days. Before you went into the room with someone with AIDS, they used to pour metho over their fingers, and if it stung, it meant that you had a hole in your skin, so you put gloves on. If it didn't sting, your skin was intact, because that's what the skin was for. So, gloves when handling blood and blood-stained body fluid, not as is taught in TAFE now, where you wear gloves for making a bed, in case there's some blood in the bed. Don't know how you make a bed with gloves on. The goggles when you're likely to get squirts in the eye, and an apron when you're likely to get dirty. And that doesn't depend on what that person's got. It depends on what you're doing, doesn't it? So if you're doing something when you're going to get dirty, it makes sense to protect yourself. Not if someone's got HIV and they're intact, pure, like me, you wouldn't need any of those, would you? Because you're not going to be contaminated. So it's again a means of making you think. So the thing that we now know is that most infections are self-infections. And interestingly enough, I heard the other day that a young scientist from WA has just won a scientific award. Did anyone else hear that? Somewhere in the UK for her work on proving that most infections are self-infections. So you see what I mean, that what goes around comes around? Suddenly everyone twigs, oh yeah, they're self-infections. So it's because something's gone wrong. We've got a hole in us, or we've got a tube in us, or something that's allowed bacteria from the outside to get where it's not supposed to be. 24% are cross-infection, which is bad. But isn't it interesting that only 1% is about equipment, and yet how much fret goes into what sort of equipment we've got, and how sterile is it, and how much expense is it, and we can't reuse it because we might damage someone with reusing it. So we waste a lot of resources and money in that area. So transmission of infection happens in 3 ways. We look at endogenous, which is self-infection, and that's brought about by medical intervention. It's sort of called iatrogenic infections these days, when someone has medically interfered with you. And so surgery, IV devices, respiratory therapy, something that's allowed microbes to bypass your normal barriers. Autogenous is what you get when you go into hospital. And this is what this girl has shown, is that we go into hospital with our own organisms, whether they be MRSA, VRE, or whatever, they are ours. And it's in this hospital environment that they can be spread from one person to another person. So they don't pick them up in hospital, they take them in and share them. And it's usually on the unwashed hands of staff. So, and of course, cross-infection. So self-infection is due to microbes already present on or in that person. And we have to remember that you and I carry around a kilo worth of microbes as part of our normal indigenous flora, which is always nice to remember when you weigh yourself, isn't it? Minus a kilo. And maybe one of the already colonized surfaces and abnormally colonized privileged surfaces, because we've got certain areas in our body that are totally free of microbes, like our kidneys and our lungs and our brain and so they may become colonized because they've been allowed entry in there. And this ensures that one iatrogenic or medically acquired infection is likely to develop a second and a third. So interesting enough, I don't know whether you remember, see I'm showing my age, I know, when a patient came into hospital for surgery, you used to put them to bed and sponge them, to put them into the hospital mode. And you would notice then whether they had any infections at a remote site. And that isn't done these days. And I've been in theatre when a patient has been prepared, anaesthetised to have a hip or a knee done, and the surgeon strips off the bed clothes, and there's an ulcer on the ankle. So surgery is cancelled because you know that whatever is in that ulcer is going to end up in that hip. And I remember once a lady coming back into hospital with an infected hip, and they drained 100 mils of E. coli from her hip. And as it turned out, she had had an E. coli urinary tract infection at the time of the operation. So it was her own organisms that mucked everything up. And so now it's being proven all over again. So these are sort of examples, I suppose. These are, if you're looking at a medal tally of hospital-acquired infections, urinary tract infections get the gold medal. You don't take much notice of them because they don't cost very much to cure, but they're mostly following catheterization, because no matter how good you are, you create a certain amount of trauma to the mucosa when you catheterize a person. I always tell ladies when they go to hospital to keep their legs crossed because everyone's after them. So surgical wound infections get the silver medal, and it's always about risk assessment. You know, we assess patients for their risk for surgery. Everything from you and I would be scored with 6, so we wouldn't get the infection. But some people that are going to die anyway, and we'd be scored a 1, sorry, someone that's going to die anyway is scored as 6. And so when you look at the cause of a surgical wound infection, you look at sort of what risk that those people are, and we all know those risks. And bacteremias are usually, again, due to invasive devices, because somehow or other that organism has to get into your bloodstream. And of course, a tube is a very good way for it to get into your bloodstream. And the same with chest infections following intubations. And we all know that our ICU patients all get chest infections because everything has bypassed the normal defense mechanism that the good Lord gave us. So we know that 20 to 50% of elderly people have bacteria in their urine at any one time. And it isn't going to kill them. What is going to kill them is the antibiotics that somebody puts them on. And it's all been done, it's all due to the risk factors. The bladders don't function like ours do. The men have an increased prostate size. They haven't got the pelvic floor muscles that we've got, or they've got something else wrong with them. And one study showed that 70% with urinary dysfunction had bugs in their urine, and 38% were incontinent and 20% with catheters. Self-infections, because the bugs from the outside get in. There was a study done a long time ago that if you think about a newborn baby, its urethra is that far from its anus, and it sits in pooey pants all day sometimes. They never get urinary tract infections because every time the bugs from the outside want to go in, the baby wheezes, doesn't it? Which is how the good Lord made us, to keep us sterile. This constant washing doesn't happen because of all these things. So the bugs can migrate. So they say that the bacteria are always present in elderly females. When are antibiotics indicated? Very rarely. You remember the stage when the only thing you ever gave for urinary tract infections was a stuff called pot-sit, which altered the pH of the urine, and that's what we're going to go back to when we don't have any antibiotics. IV devices. Look at the sort of organisms that cause IV devices: self-infections, skin organisms, self-infections, because you've given the organisms from the outside entry to the inside. When you start to get peculiar things like strep viridans, you wonder whether whoever ever put the IV in might have sucked it before they put it in, or sort of licked it to make sure that it's okay. But on the whole, they are skin organisms. And of course, good old Staph epi up there. We talk about MRSA. What about MRSA? It's the most difficult organism to treat, and it just loves tubes. Operating theatres, wounds happen in operating theatres. They're endogenous in origin, so they're their own patient's organism, and it all depends on the risk factors. Operating theatres are beautiful places, aren't they? I saw it described in this way once, which I thought was rather good. To a surgeon, sterility starts with the idea of someone wearing a certain type of clothing, usually green, leaning over a sink. This grants immediate entrance to the OR, where he will be approached by a young lady who will dance around him whilst enrobing him in one of the magic sterile gowns, usually blue. Without this choreography, the surgeon will not consider himself sterile. The fantasy of the surgeon with regard to sterility are wilder than anything seen in any X-rated movie. I once asked a surgeon how he knew that the laparoscope was sterile, and he said it comes wrapped in green paper. To the administrator, sterility means immunity from lawsuits. And to an OR nurse, the creation of an imaginary perimeter, usually around a wound site, called a sterile field, which is characterized in his or her own imagination. Others get into trouble because they don't know where it starts or ends. So there's a lot of lovely ritual in an operating theatre, isn't there? Beautiful. So, but the sort of organisms that cause wound infections haven't changed. Operating theatres have changed because we now have to spend billions of dollars on air changes and airflows and sterile instruments, but the actual organisms that cause wound infections, the only changes that have happened is they've become resistant to antibiotics. They are all self-infections. So, challenges: the approach to infection control is less scientific than it should be. Examples have been the knee-jerk reaction that we get when we suddenly have VRE and SARS, which I think Charles Watson's probably going to talk about SARS, isn't it? Because it's usually real. This knee-jerk reactions could be viewed as unprofessional in the world of infection control, I believe. More logic and less woolly thought would make it easier to identify and cut out useless rituals and avoid new mistakes. So I think some practices are unnecessary or wasteful, or both. And money, of course, and time is very valuable. Infection control practices need to be reviewed from time to see if they're effective and cost-effective. And some are so ignorant of the eogenic infections that they actually deny their existence. So why link nurses? A good team makes an enormous difference. Having more people around you who actually are aware and have knowledge of infections, the better it's going to be for everybody. And of all the specialties, and I've worked in a few, I think infection control is the most interesting. It's the most challenging because of all the ignorance that we have out there, that you constantly think that you're banging your head up against a brick wall, but my head's pretty thick these days. So good luck in your knowledge, and just remember, that infection control must be based on science. We spout evidence-based practice all the time until it comes to infection control. And no one needs to know the evidence. If someone asks you to do something stupid, ask them why, and see if they have an answer. So rituals are a ridiculous waste of time. I don't like looking ridiculous. Policy should be based on scientific evidence. Changes of patterns of disease should be considered, and we do know that that's happening all around us. And always ask questions, and always remember Semmelweis. He must be revolving in his grave. He died of syphilis, by the way. I was once, because he was known as the grandfather of infection control, and I was once introduced as the grandmother of infection control. And I don't think I'm that old, and I don't know if there's any history of sexually transmitted diseases in my family. So thank you for inviting me to talk. Thank you. Can I drink it now?
Oh, if you wish. Thank you very much, Madeleine. Does anyone have any questions for Madeleine? We've got one.
No, just when you were talking about UTI, especially in the elderly.
Yeah.
Finding that balance, isn't it, between antibiotics and what the infection does to the old client?
Yeah, I mean, the best work I think ever done on UTIs is John Pearman's work. Does anyone know Professor Pearman? He was microbiologist at Royal Perth Hospital. He's now retired, but he lives in North Fremantle, and he's a great speaker. But Shannon Park Hospital had the lowest rate of urinary tract infections in a spinal unit in the world, to the point where he used to be accused of cheating his figures. And this is all John's data. And so they tend to think that bacteria don't harm elderly people, and that antibiotics should be reserved with them for serious sepsis, and then you give serious antibiotics like IV gentamicin and amoxicillin. So the recommendations are usually to increase fluids, which is hopeless, isn't it? Because they're not going to drink. And alter the pH of the urine, which of course is what Pot-Sit did, didn't it? So you either give cranberry tablets or urine sachets. And it's a bit like your garden. When you alter the pH of your soil, your garden dies. If you alter the pH of the urine, the bacteria die, because they're all pH assessed, and you wouldn't leave them on them forever because they would adjust, or other bacteria would come there. So, I mean, what do you define as being a urinary tract infection in the elderly, apart from doing a dipstick? And a dipstick has been shown by John Pearman. Nitrites mean that you've just got fecal contamination. And the only way you can get an accurate reading with a dipstick is with a sterile specimen of urine, which you can only get, of course, by catheterization, and then you're doing more harm than anything.
But we do know that the elderly, if they have a urinary tract infection, that they have behavioural, or they can have behavioural changes, can't they? Which in turn will then put them at risk of certain forms of
that's right. Yeah, that's right.
That.
You alter the pH of the urine and try and make them drink. It's the first line management first.
Yeah.
If you've got pyrexia, then yeah, I mean, then you need to give serious antibiotics, because it is unusual for an old person to mount a fever, isn't it? I tell my GP that when he takes my temperature. Don't forget, we don't react at my age. So yeah, it's an assessment thing. But the unfortunate thing is that the antibiotic given is usually stab in the dark therapy, isn't it? Antibiotics are either given for treatment when you know what the organism is, and you give the right antibiotic, or they're given for prophylaxis to prevent an infection, or they're given for empiric therapy when they guess. And most of them are guesswork. If you know what the organism is, yeah, that's right. Yeah. Yes. Yeah. Yeah. Yeah.
Catheter pack, but catheter, right? Isn't that silly? Why are you going to catheterize a woman who's just about to push a baby out?
Yeah.
In the back of the car,
yeah. And how do you find the urethra at that particular point in time?
The environment you're in at the time.
Yeah.
And I remember when I was years ago, when I was a midwife working,
Why? And enema. And shave. That's right. That's right. That's right. That's right. That's right. That's right.
I still don't understand why.
No.
I didn't put it in.
No.
I didn't put in
No. No.
size 12
No.
and the thing is, you forgot the when you catheterize the woman in the back of the car.
That's right. That's right. Yeah. And why? And why? And why? I went down to radiology once because I noticed that this lady had gone down there for an X-ray. They'd catheterized her prior to the X-ray, and I asked them if they do that with men as well, and they said no, it's too difficult. So that's why I say you've got to keep your legs crossed because we're easy sitting, aren't we? Yeah. I think asking why is very good because there needs to be a reason, and half the time they don't know the reason. It's ritual. It's a ritual, isn't it? God. Yeah. That's right. I'm glad you didn't do it. Yeah. So yeah, urinary tract infections is difficult, I know, and we do feel that we have to do the right thing, but it's giving antibiotics the right thing, especially when you think that they're mostly E. coli. We now have multi-resistant E. coli. We have multi-resistant Pseudomonas. We have multi-resistant everything. Is it doing anything? I think the only time we gave antibiotics was when they had pyelonephritis. So, big pun. You'll have to excuse me, but I say what I think. Nail polish. There isn't any science in nail polish. In fact, they say that people who have their manicured nails actually look after their nails probably shed less nail particles than anyone who doesn't. Artificial nails, there's a lot of work on that. They do grow gram negatives and they do grow fungi under artificial nails. Everyone's got square white nails these days, haven't they? And they do grow artificial. Oh, sorry. and they do grow gram negatives and fungi underneath them. So they really don't have any place in healthcare. But nail polish, I think, just looks unprofessional. But there isn't any science in it. And I think we've always got to have science behind what we recommend because you're going to have holes blown in it if you haven't got science to support you. And there is science on artificial nails, but there isn't any on nail polish.
Are there any more questions for Madeleine? think on that point, then we will break for a cup of tea.
Thank you.
And we'll be back here at quarter. Thank you, Madeleine.